and we have two young aspiring energetic people joining us as faculties for the day who who are having real-time experience with many palliative care patients. So it is indeed my pleasure and privilege to welcome our faculties for the day, Miss Sara Varghese and Mr. Emil George. They are serving as the social engagement officers with Palliative India Trust, both with us for about 1 year now. Ms. Sara Varghese had completed her MSW from Manipal Academy of Higher Education with specialization in medical and psychiatry, and she is presently handling the psychosocial aspects of beneficiaries in the inpatient and outpatient unit of Trivandrum Institute of Palliative Sciences, TIPS Trivandrum unit. Mr. Emil, who is also joining us for the day, is also a postgraduate, having completed his MSW with the same specialization in medical and psychiatry. And presently, he is in charge of handling the psychosocial aspects of beneficiaries under 3 link centers mapped under the Palliative India in Trivandrum. So, indeed, I hope that this would be a very enlightening session because they might be sharing their own real-time experiences with the patients as well as we go through the session. So without much delay, it is over to you, Ms. Sara and Mr. Emil.
Thank you, Sripriya, for the warm welcome. So good afternoon all. Welcome to the session. Today's session is on the topic psychosocial aspects of care and a small topic, genogram. Next slide. So let's brush up what we already know about palliative care. The World Health Organization's definition for palliative care is here. Palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification, impeccable assessment, treatment of pain and other problems, physical, psychosocial, and spiritual. So this is the basic difference between curative treatment and palliative treatment. In palliative treatment, we focus on improving the quality of life of the patients, alleviating the suffering, and through constant and continuous assessment, we try to get the good picture of physical, psychosocial, and spiritual parts, and also to intervene and relieve the suffering of patients. Whereas in curative settings, the prime objective is always to cure the illness. They don't look beyond the patient. Next slide. So there are some different concepts in palliative care. The first one is total pain. In this concept, we believe that the physical pain is compounded by the patient's current life circumstances, his social status, his psychological states and all. So even if we give medication to cure the physical pain, it won't be healed. Even if the pain is healed, there will be other sufferings that is bothering the patient. So we see the concept as total pain. The other term is that social diagnosis. When we diagnose a patient in palliative care, the diagnosis is made in relation with his biological, social, and other environmental factors. That is, we see the person in his situation. That's why we always have this home visits and all. We want to see the patient in patient's own home. Next slide. This is a pictorial representation of total pain concept. In this, we can see that the first one is the physical. The first priority always goes to the physical part of the patient. Then the second part is psychological, and third part is socio-economic, and then spiritual. So the medical team, the doctor and nurse attends to the physical part. They try to relieve the sufferings in that area, whereas we social workers attend to the psychological matters. Whenever we do screenings, assessments in psychological aspects, and if we find it to be severe, we hand it over to, we suddenly refer to the psychiatrist or psychologist. And then we have socio-economic part. Here we try to explore the social relationships of the patient, how the social roles of the patient is changing, how the family dynamics is working, all those kind of things. And then we also try to assess the economic part, how the patient's economic status is going, how the treatment is going to be a burden for the patient, what all are the medical expenses that is going to come throughout the course of the illness, all those kind of things. And we also try to implement various interventions and ways to relieve these sufferings. Then we have the spiritual part. In the spiritual part, we try to identify the patient's hope, patient's understanding of life, what is his meaning of life for him, and all those kind of parts. The spiritual part is the most difficult part for us to assess, A constant and continuous rapport with the patient is required to assess the spiritual part. Next slide. So why is psychosocial care important in palliative care? Because once the diagnosis is made, or if once a patient is affected by a life-limiting or life-threatening illness, the entire picture of the patient changes. That means till yesterday he was a normal human being. Today onwards he is having a lot of challenges, lot of questions about his conditions, lot of uncertainties in his life. So to overcome these uncertainties and challenges and stresses, we help the patient. We social workers and all other professionals help the patient to overcome these challenges. Our prime objective is always to make the patient independent and improve the quality of patient's life. And once there is this diagnosis, the patient's entire perspective of the world changes. Till yesterday, he was seeing the world as normal like everyone else, but once the diagnosis is made, it's something similar to a tunnel vision. The patient is only able to relate everything around him with the illness. So he will start to think whether he's being a burden for his family, or how is he going his treatment during the treatment course, how much financial expense is going to be, or financial burden is going to be on the family, how the caregiver is going to behave if he asks for something, some help or everything. So that's the second part. Next slide, please. So assessment is basically exploration of information about the person. So we want to get a pure and complete picture of the patient, the true picture of the patient. That's why we do assessment. And each time we make an assessment, we set a plan for the patient, and there will be goals to overcome small hurdles. The short time goals will be there, and also there will be interventions if necessary. So assessment assessment is a continuous process. When we see the patient for the first time, we do the initial assessment. Then we will conduct a home visit. That will give us a clear picture about the patient and his family, his community, and everything. Then the follow-up assessment will continue. Next slide, please. The aim of assessment is to understand or identify the problem areas. We already saw the four areas that makes the patient evolve. So to identify the problem areas, inside that areas are the prime objective of aim of assessment. Assessment involves collecting information, identifying and acknowledging the strengths and weaknesses of patients, identifying resources, and doing need assessments. Need assessment is also an important part, because limitation in needs creates a suffering. So need assessment also is an important part. Next slide, please. So as I said before, assessment is an ongoing process. Each time we see the patient, more rapport will be built between the patient and the social worker. So better exploration is done each time. And we use two tools for this assessment, that is purposeful observation and purposeful conversation. So there will be observations, and our conversations will be more like leading questions will be asked, open questions will be asked. So we try to explore, get as much as information possible from the patient side. Next slide. So our primary source of information is the patient, because we want to know the patient's perspective. Then to fill in the gaps in the information, we talk with the caregiver. Also, we use collateral sources to verify the facts, like friends, relatives, neighbors, etc. As I said before, home visits are an important part of our service. Next slide. Now let's go through some of the basic genogram symbols. A square denotes male, and a circle denotes female. Next slide. If a male and female is connected with a single line, it means that they are married. And if they are separated, we denote it with a slash in between of the line. And if they are divorced, or if they are legally separated, we use two slashes to mark that. Next. Now, children and birth symbols. For a normal biological child, we descend a line just from the relation of the parents and draw the square. Draw a square. And if it's an adopted child, we use dashed lines which descends from the relation. And if it's a foster child, we use dotted lines. If there's a pregnancy in the family, we use a triangle for the woman. And if there's a miscarriage, we cross the pregnancy symbol, and we draw a horizontal line to mark the abortion onto this miscarriage sign. If it's a male stillbirth, we use a small square. Instead of a regular square, we use a small square and cross it. And for the female, same small circle and cross over it. Next. And for twins and triplets, we use same square signs or circle signs originating from single point from the relationship line. And for identical twins, the lines between those children will be connected with a single line. And if there is a stillbirth or if there's a triplet and there's a stillbirth in between, we draw a stillbirth sign in between those. Next slide. Now let's see how emotional relationships are marked in the genogram. If a male and female is having a normal relationship or plain relationship, we connect it with single line. If there's a friendship or closeness, we mark it with dashed double lines. If there is intimate, they are very close, or if there is huge, great intimacy between the individuals, we mark it with double bonds. And if there is conflict of hostility between the individuals, we use zigzag lines with huge gaps in between. We also use red markers to mark this. And if there's violence in between two individuals, we use packed zigzag lines. Next. And for emotional relationship, we always use blue color as markers. So if there is an emotional abuse, same as for violence, we use packed zigzag lines. And for sexual abuse, we use two packed zigzag lines. And if there is a neglect in the relationship, that means a dashed line will be drawn, and there will be an arrow towards the one who is being abused or neglected. Next slide. Now I'm handing over to Sara to discuss the rest of the assessment part.
Good evening, all. Okay, let us discuss what are the important areas to be assessed from the point of view of total pain. Next slide. So the assessment involves patient overview, insight, family overview, a socio-economic overview, psychological overview, spiritual overview, and intervention plan. So next slide. So in the patient overview, we take the basic demographic details such as name, age, gender, and occupation before and after the illness, because if a person diagnosed with an illness, if he won't go to the job, so we for better understanding, we clear that who is the breadwinner of the family, and diagnosis, and we check that how much he is aware about his diagnosis, and primary caregiver and relations. Maybe the patient family members itself is the primary caregiver, maybe relatives or neighbors. So for better clarification and for better interventions, we understand who is the primary caregiver and the relation. And through patient overview, we get an overall basic understanding of the patient and his family. And insight means awareness of his illness. We, the social workers, understand how much he knows or she knows about her diagnosis and her prognosis in depth. And we understand what is awareness about palliative care. If he is not or she is not aware about that, we explain to them in detail. Next is family overview. Emil explained genogram in detail. So we collect a genogram, and in that we can understand any other patients in the family, or who are the intimate family members who are staying with the patient, and all the things. Primary caregiver, earlier I told, we can understand who is the primary caregiver. Maybe if the patient husband is the patient, maybe the wife is the primary caregiver, so we can understand who is the primary caregiver. And support system means from where all they are getting support. Maybe the father is not, maybe the husband is the patient, his family members are not supporting, so we understand who all are supporting them in their diagnosis, in their treatment time. And next is structure of families, so who all are staying in their families, nuclear or joint or extended family, and how much they are supporting them, and the nature of relationships, and then bonding with their family members, we understand that their relationship is stressful, or their relationship is close or stressful. We'll understand that and we'll mark in the genogram. Next slide. And ecomap is the another tool we use to analyze the to identify the support system they having, and it is a pictorial representation that helps to visualize social and personal relationship of individuals with the environment and with the larger society. This is the definition given by Anne Hertman, and it is a snapshot view of important interactions of patient family with other systems, groups, extended families, individual, organization, associations, etc. May they get support from any NGOs, or may from any extended family members or relatives, may they get support from any organizations or charitable trust or any religious institutions. So we will analyze or we understand their support system. Next slide. This is the pictorial representation of the ecomap. So may they get support from the health services. So may they get help from neighbors, workplace, government services, community services, religious institutions, friends, clubs, school, volunteers. So we understand from where all they're getting support. We ask them how long your friends visiting you, or how is your neighbor, are you having good bond with your neighbors, or are you missing your workplace. Through these questions we understand their from where they're getting good support. Next slide. This is socio-economic overview. Through this assessment, we understand that advocate basic amenity, they having basic amenities such as food, clothing, and shelter. And we understand that who is the primary breadwinner of the family, because if they're primary breadwinner in the family having the illness, due to illness may he lost his job. So currently who is the primary breadwinner and who controls the current financial expenses and all the things that we look. And other sources of income, currently who is helping them, their relatives or any NGOs or charitable trusts are helping them. Then community support, are they getting any community support from their PHC center or from any churches or temple or mosque, from where they're getting any community support. Next is government schemes. Are they getting their government linked to government schemes, such as if the patient having CA, are they getting any CA pension? So we'll look over that. And the education of the children. If the breadwinner of the family lost his job, may the education of the children may be in a stressful life. So we'll check that the education of the children is going good and all. And debts. Most of the time, hospitalization makes a lower middle class people like financial instability. So we'll look at how much they have they have debts and all the things, and other financial vulnerabilities. Next slide. Next is psychological overview. In this thing, psychological and spiritual overview, we couldn't assess in the first initial section. So after building a rapport and after sitting with them many sessions, only we could understand the psychological and the spiritual overview. So psychological distress, in that the patient may have diagnosis with an illness. He have like anxiety and depression. He may bargain that he doesn't have that illness, or deny that he doesn't have that illness. So may the patient have psychological distress. And emotional support. Most of the patient, they having emotional trauma in their life. Most of the hospital, they won't support emotionally. So we understand their emotional trauma and we are supporting them. And anticipatory grief. And some people having grief because they came to know about their diagnosis. And coping mechanism. And we'll understand them, which is the strategy they use to reduce their unpleasant moments and all the things. Next is spiritual overview. That is connection. Connection, in that we ask them who are the persons or community you look for to support you, and what are the roles do they play in your life, and how is your life situation, how affected your feelings about yourself and your family relationships and all. And in meaning of life, we ask them what is the most important thing in your life and what are you most thankful for. So we will understand that and we will encourage them. So strength and comfort. And we'll ask them, is there anything that is comforting to you, or what help you to stand in the difficult time, because when they are diagnosed with an illness, we'll ask them what is the most the important thing in their life to comfort themselves. So that all we understand and will help them. And next is hope. And some people have a hopeless feeling, why this illness came to me, why me, these questions in their mind. So we'll ask, is there anything that you hope for, or is there anything that feels unfinished in their life? So we will address all these things in the psychosocial aspect. Next. Next is general interventions. These are the general interventions we are doing in Pallium. First one is psychoeducation. So we educate about their illnesses, and we have sessions with the patient and with the patient caregiver and the family members to discuss about their illness along with the multidisciplinary team. Next is family meetings to if they have any family problems, or if having any issues in the family, we'll do family meetings and listen, and we connecting them to government schemes and all the things and facilitate. We only facilitate them, they have to take decision in their life. So we facilitate them to connect with various PHC, primary health center, care home, and etc. And rehabilitation, and we are doing here vocational rehabilitation, physical rehabilitation, and all the things. And bereavement support. If a patient under our care dies, so we providing bereavement support, and our team call after 7 days. If we found any risk there, we do visit their home and we follow that cases. And next is supportive counseling. Next. And the possible social impacts. I found in here. Social isolation, dependency, because most of the patient in a traumatic paraplegic, or they are wheelchair bounded people, they may always depend on others for their daily living activities. So these we found here. Financial instability, lack of social support. If a person diagnosed with an chronic illnesses, may his support system withdrawn. We found out these issues. And debts, loss of work, interpersonal issues, inadequate facilities. Possible psychological impacts, feelings of shock, uncertainty, and hopelessness. If a person came to know about his illness, he denies it, he bargains it, and he may have that grief that he won't accept that, and they may have poor insight, anxiety in their life, and suicidal ideation, wanting to hasten their life. Most of the patients, if they're having more pain, they wish to die. And these are the situations we are seeing in our setting. And poor coping with the illness. Earlier I told psychosocial and species suffering is real, but can be difficult to recognize and treat. This can manifest as a physical complaints. Next. Vulnerable populations. So through socioeconomic assessment, we categorize people and we providing more care to vulnerable populations. And these are the people coming under the vulnerable population. And first was living alone. Maybe the patient is living alone in the house. No one is there to take care of him or her. And next one is elderly without support, and no one is there to support her or him. A single parent, maybe the patient, only the patient was having only one parent, or and multiple patients in the family. In the family, maybe 2 or 3 patients having CA, and victims of gender issues, domestic violence, or physical or verbal. Then next is individual with mental health issues. We considering them, and we taking special interventions for these kind of people, and individuals with suicidal ideations, socially isolated people, substance users in the family, individuals in extreme poverty, and vulnerable populations. We are following up these patients twice in a month, and we are always keeping touch with these category people. Next is caregiver. And caregiver means the persons who are caring the patient. So we always have to respect those individuals and acknowledge their complex role. That we have to take care of their mental health also. We are calling them as a invisible patients because they are also having many emotional trauma, physical pain, but they are not showing. So we have to respect them and never dehumanize them by calling them as a bystanders. Please mention them as a caregiver. Next. Next is we are asking our patients, like, what do I need to know about you to help you better? In our setting, we'll ask the patient in their maybe the an end of lifetime, or the many hopeless situations. They feel like, they won't share anything to us. So we ask them to what we should give for them, because at the last stage they have many wishes and unfinished wishes they have. So when they maybe their birthday time, so we celebrate their birthday in our setting, or their family members, close family members birthday, or any wedding anniversary. Or they we mom with through them we understand their uh, pain, and we arrange or we take appropriate interventions in our settings. And now we'll see one video. uh, okay, this is one of wedding anniversary celebration. This is one of our patient, and we celebrated their wedding anniversary in our IP setting. And these pictures are taken with the consent of the patient and the caregiver. And this is vocational rehabilitation. We are supporting patient and the caregiver to stable their finance. And this is support for children. We are supporting patients, children, men, emotionally and educationally. So we are conducting Kutikutam program to emotionally and educationally support the children. And always remember, evaluate our interventions, assess how the patients and families are benefited, and assessment have to be revised and updated. And we are always updating our assessment through regular home visit or through phone calls, and reach out for help if needed. And there is an art and science in psychosocial care just as in medicine. And thank you for listening us. Thank you so much.
Thank you.
Thank you, Sara. Thank you, Emil, for that concise presentation. So we do have a case presentation also for the day, but before moving on to that, would anyone of the participants would like to share their insights or their thoughts regarding the same, regarding the particular topic? Any specific queries you would like to know more about? In that case, I think maybe we can move on to the case presentation and then come back to the discussions again. Dr. Amrita?
Yes, thank you. I'm Amrita Shrestha from Nepal, and I work at Green Pastures Hospital. I'm a consultant pediatrician, so I work with children with disabilities, and I have this interest to go into palliative as well. So I'm taking up this course, and let's start. I wanted to raise my hand earlier, but then I thought I would just say it, after my case presentation. So I think I'll wait until I finish, and then maybe I have more, not questions, but just, I don't know, few things that I want to share. So this patient is a 18-year-old female with diagnosis of postpartum transverse myelitis with paraplegia, status post-flap coverage of multiple grade 4 pressure sores on bilateral greater trochanteric sore and sacral sores. So this time the patient came with complaints of burning sensation of the wounds. And she had done debridement a month ago. And this time she came for wound management, further wound management. So the patient developed wounds on the sacral region and greater trochanteric region after 1 month of being diagnosed with postpartum transverse myelitis. She underwent debridement of the wound and was sent home with instructions for daily wound management, high protein diet, and regular change of position. The wound on the sacral region healed through secondary intention, and after 1 month, the bilateral greater trochanteric, the sores were covered on 2 settings. So on examination, the patient, at present, the patient is well nourished and well oriented, lying in prone position. Vitals are within normal limits, but she has spasticity on bilateral lower extremities. And local examination, flap is satisfactory with mild soakage on the flap site. Psychosocial aspects. She's a 18-year-old married female with 1 child who is 8 months old. And the husband is the primary caretaker, currently jobless. And the husband wanted to go abroad for job opportunities, which actually led to patient's anger and resentment towards everyone. At that point, she was very low, and she wouldn't even talk to anyone. And she was very concerned who would take care of her and their child, what would be their future like. And the medical expenses at present is actually being covered through charity. And one thing I forgot to add here is that the husband currently is staying with her and not going abroad anymore. So she's, well, we could say she is happy for the moment. So she's under, she's taking iron, multiple vitamins, and zinc, lactulose, baclofen, pantoprazole, antibiotics, paracetamol, and she's having occupational and physiotherapy as well, and prone positioning and daily dressing of flap as well. So the main concern they have is she's not able to take care of her newborn the way a new mother would like. And of course, their financial needs, even though her medical bills are being covered by charity at the moment. But of course, they do have their financial problems, and of course, their future and their child's future as well. So I put a very vague term here, nothing specific, because I think they don't, it's how they feel. Yes. So to summarize, she's a 18-year-old married female with one child diagnosed with postpartum transverse myelitis, who's undergone flap coverage for her multiple bed sores and receiving medications, physiotherapy, as well as occupational therapy. So the points to be discussed, the first one, what kind of psychological support does this family need? Second is, how can we support her to take care of her child? And third is, what would be the long-term goal? Yeah.
Thank you, Dr. Amrita, for that. I believe it is a very relevant case scenario for today's topic. So, before we move on to the faculties, maybe someone else would like to add any points or clarify any points based on this case. Any extra details someone would like to ask Dr. Amrita or in that case, maybe we can put the discussion points to the panel and the audience. Chat coming in. Dr. Revati wants to know what about the patient's parents? Because Dr. Amrita, would you like to throw some light on that?
So I think it's a known universal fact that the wife would always want that her parents would take care of their child. So that was one of the points that came up when the husband was actually planning to go abroad. So who would take care of the baby then? And of course from the father's side, of course they wouldn't want their grandchild to be somewhere else, and then the mother wouldn't be happy because the grandchild would be with her in-laws. So they're not actually in a state to take care of them, but then of course they can have a family support that we could say that they could receive for the baby, but then that also produces another psychosocial issue, I think, for the mother especially.
Yeah, very stressful condition that might be for a that too. As far as I could personally see from the case, just 18-year-old. Maybe we could say that she herself is a child in our current settings. So very sensitive case.
On that note, what I wanted to earlier, what I wanted to point out was that, so we were talking about the woman being the primary caregiver, and we see that how how they invest themselves into taking care of their husbands, or like the man, whoever, like the son or whoever. But then what when the role is reversed, like in this scenario? Because even for me personally, my concern was, because I mean, even he's an 18-year-old man, he's very young, and maybe he will just choose to have not take another wife, or those kind of issues. Yeah, so maybe we could discuss on these things.
Dr. Mohammed Sajid wanted to know what job is her husband doing. Well, I believe that he basically wanted to know whether the husband is educated and doing a well set up kind of job, or a daily wages job. So I believe that is what you wanted to understand, Dr. Sajid. If you could.
At present, like I mentioned, he's jobless because he's at the hospital with his son, taking care of his wife. That's why one of the reasons why he wanted to go abroad was to make money. But then that would also cause another dilemma there, like who would take care of her and everything. And I see the question here. So yeah, the paraplegia is permanent because she did get steroids, but then it wasn't reversed. So probably, yeah, it is permanent. Sorry, I didn't really get the question. How the husband is 18 years old as well. Are these two children who we are dealing with? Sorry, I didn't really get the question that well.
Dr. Dhanwanti, would you like to throw some light on that? The second part of the question, basically, are these two children we are dealing with?
Yeah, what I wanted to know is if the wife herself is 18 and the husband is also only 18 years old. Firstly, God knows what age they've been married. In India, it is not even legal to be married at such a young age. And then she's had a child and already developed bed sore. So that means significant time has passed since her paraplegia and the birth of the child. And number three, that if the husband is also 18, there's obviously no education involved and everyone's studies has come to a standstill. So I just wanted to understand from Dr. Amrita, is that the situation that they are also like children themselves, you know? So
Yes, exactly.
okay.
Yeah.
Oh, thank you.
Actually, I believe the situation of the treating doctors would be also very like, how to convince them, how to educate them. As Dr. Dhanvanti correctly said, when we are, maybe we can say older children, them, the husband and the wife. So it might take more time to communicate to them what is to be done and how to be done. Sara and Emil, would you like to?
So in this case, we can give psycho education to the patient so that she can accept her condition. And if she is able to accept her condition, and if the husband is able to go abroad, their financial crisis will be over. And if it was in our setting, we would recommend a caregiver. And if they are financially very poor, we pay for the caregiver, and that's what we will do. Sorry, anything to add?
And we mentally support her, and we will connect her to many support groups, and we will encourage her to come out her emotional trauma, and we will try to, if their family financial instability is there, we will try to rehabilitate. We have to provide some rehabilitation for them.
Also, she's paraplegic, right? So we have special trainings for paraplegic patients. We have a halfway home, which trains them in doing everyday activities or overcoming their limitations. So these are some of the interventions that are possible in our setting. Thank you.
Okay. Dr. Kanmani had suggested that the families have to step up and help these kids. Very true, Dr. Kanmani. Like, they themselves are kids and they have a very small kid, 8 months, so to say, to take care of. And then they are going through this health conditions. Of course, the families will have to step up and help these kids. Dr. Amrita, would you like to throw some light on that aspect?
Yes. So Ian, I think he has a question. I'd like to answer this. We do have counselors, and yeah, we have really good counselors, I would say, and we also have vocational rehabilitation as well. So we do have all of these things. But yeah, even like for me personally, I feel like how like these things are there, but then how to, I don't know, like, okay, these kids, how to just support them. I don't know, I think it's just a personal feeling rather than a professional one at the moment. But yeah, we do have counselors and trainings for them. Yeah. Is there any other question?
It's like just like someone in our family going through that. When we are seeing people like this, like we extremely want to do something, but then at times our hands are held up professionally or say, so to say, personally as well. Because when, as you mentioned somewhere in the case, that the wife was very angry and depressed when her husband was, maybe she was right, she was just a little am I audible? Okay. She's a
Yes, you are
very
audible.
young girl and she's having such a physical condition, and then what might have mattered her more would be a physical presence of her spouse rather than he going abroad and seeking a better future for her and her kid and their kid. So that might have been going through her mind, we cannot be sure, but still. And Dr. Kanmani has suggested the patient is not quadriplegic. She can be taught to take care and nurse the baby. If that is the main concern, as it was mentioned that the taking care of the kid was one of the main concerns of the couple. So Dr. Kanmani has suggested this.
Right, she's nursing the baby. Yeah, but I feel that rather than literally taking care of the baby, it's more of a psychological war that she has, about taking care of the baby, like not being able to be the mom that she needs to be for the baby, maybe. But yeah, she can take care of her child, of course, because she's learning to use the wheelchair and everything as well, and her upper body strengthening exercises are also being done. So yeah.
So true. Being a non-medical person, maybe I can recollect that feeling when you have been dreaming for a whole 9 months or 10 months about how to take care of your baby once he or she comes out as a normal human being, and then at all of a sudden the situation changes and you are not able to provide the care which you had dreamt of. So whatever care she gives maybe would be enough for the baby from the medical part of your, when a third person is looking at, maybe they'll see that okay, she's taking care of the baby as far as she could, but then there was a dream which she carried which is not happening. So that might be the reason, one of the reason for frustrations. So, Sara or Emil, can you just guide us how we can motivate her, or how we can educate the mother, particularly that when she is taking care of the baby, when she is nursing the baby with her limitations, she is doing a wonderful job. Of course, words are the best motivators in the world, but still, any other tips or suggestions you would like to give here?
Anyway, she will require a caregiver for sure, because a child growing up will obviously need support.
And we will analyze that any support system in their family, her parents or his parents are there to take care of the child, and we will educate them. We have like multidisciplinary team, so we educate the mother, try to educate the mother about the motherhood and all the things.
And now, since Dr. Amrita had said that the father is staying behind, leaving his dreams of going abroad and chasing his dreams, so maybe that also might help them in bringing up the child together in coming days. Dr. Kanmani was suggesting mother itself being a grown-up child, counseling her is going to be sort of. Dr. Amrita, I think you would be the best person to confirm that.
And probably have a, I don't know, family therapy sessions or something, so that all of them are in the same, on the same page.
Correct.
Hello, can I talk?
Sure, sir.
Very, very, very difficult scenario, Dr. Amrita. But then we cannot become emotionally overwhelmed by the situation. As rightly said by our teachers of this session, we should have somebody to support the child, the mother, support the mother. And say, for example, as you mentioned before, bringing in the family, seeing how capable the grandparents are, either the doctors, either the son, either the father's parents or the mother's parents, see how supportive they are. Are they capable of taking up such a effective way of taking care of the child? Because they are the best examples to show the mother or father how to take care of a child in such scenario, because they are definitely elder than both of them. So staying with them for some time and showing that they are the best caregivers for the child, the mother will gradually get confidence out of it. Father will get gradually confidence of it. Because to send an 18-year-old boy abroad, for what purpose? Absolutely not possible. I can't imagine sending my 18-year-old son for working outside India. So obviously, getting the confidence of mother and father by giving a very able caregiver, that is very important. Suppose the grandparents, both four of them cannot handle this scenario because based on the family chemistry, then a team like a Palliative India's work, we can allot somebody to them by giving them some small emoluments because there is a charity going on there. Again, somebody who is who can take care of the child like a grandfather or a grandmother, stand with the mother, build up her confidence, and then gradually the mother will start getting the feeling of, yes, these are the way I should do things. This is the way I should do things. The father also feels, yes, this is how we support each other. And over a period of time, mother gains confidence, father gains confidence. By the time father can have a plan to go abroad. So it's a process that should go on for some time, but a gradual effect should happen if you handle the situation in this way. This is my personal feeling. Thank you very much.
Thank you. Thank you.
Could I speak for a moment? Would that
Sure,
be
sir.
okay?
Sure, sir. Please.
I think it might be helpful to compare and contrast the situation in the UK with this scenario to that of Nepal. I'll start with some of the things that happen within the UK situation. Certainly the accommodation and suitable wheelchair friendly accommodation with ramps and adapted bathrooms, that would all be provided by the state through the benefit system. And financial support would also come through the benefit system within the United Kingdom. So all of that would be picked up by the state, which removes two of the major areas of concern, both for the mother and the father in this situation. But the psychological aspect of it is dealt with by often a mosaic of individual charities and support groups. And as the previous speaker said, the family is probably the single key support group in the situation. The financial state support is limited. You will always be sitting in the bottom 10% in terms of income in society because the support benefits are relatively low. I remember a wheelchair user once telling me that for the first 5 years after they were confined to their chair, they really found it very difficult. And it wasn't until 5 years later he wanted to continue to live. So you're looking at a very long period of time for this young woman to adjust to a new situation. Often seeing someone who is perhaps already in a wheelchair, able to care for a child. So someone else who can demonstrate that it's possible can be very inspirational as a mentor. And with improved technology now, you can interconnect people using mobile phones in a way you couldn't do just 3-4 years ago in terms of support groups. But I think, as you said, the family is absolutely key, because without support of both sets of parents, it would be very easy for this relationship to break down and for a husband to decide to leave that situation, and that would leave this woman completely destitute and the child destitute as well. And it's got challenges on so many different levels, and challenges over the next 3, 4, 5 years, particularly in Nepal, with the difficulty of community-based rehabilitation and the limitations there. So although some things are good in the UK, that we've got access to fiscal support, the psychological support and the readjustment still falls back on exactly the same mechanisms that you're using in India or Nepal, and primarily the family and relationships, the community and voluntary organizations. It's very interesting. The two are very, very similar.
I think, thank you for those very true and beautiful words, Dr. Sajid and Dr. Yan, because I believe everyone would agree 100% to whatever you both said. And as far as the last part goes, yes, as far as the humans are concerned, it is the basic emotions and the human same in all parts of the world. So I believe that is where the palliative care also plays a vital role in our healthcare, because the palliative care teaches us to see all humans as complete persons, see their pain as total pain, including the psychosocial aspects as well, apart from the physical pain. And that is what we are going through today. So maybe I think we have one more discussion point left at that. What would be the long-term goal in this particular scenario? Of course, as already mentioned, it's very confusing situation. So, Dr. Amrita, would you like to start up that point? Like,
Yeah, I think we sort of covered it a little bit because we've discussed so much. Yeah, and I think the first foremost thing would be to for the husband and the wife to have a actual, good relationship between them, so that they are strong enough, like, that they'll be their support system foremost. And then comes the, extended family and things like that. And of course, there are other things like vocational trainings and, to help or to teach or to educate them in different aspects as well. Yeah.
just out of curiosity, as a mother of a child, I just wanted to know, hope the child is doing, the 8-month-old child, hope the development is normal?
Yes, he's being taken care by all the nurses and everyone who ever visits the ward, so yeah, he's a happy baby.
Nice to know that, because I was just curious that these dilemmas being faced by the parents might not affect his childhood and his rights as a child. So maybe we can hand over, if anyone else is not having any particular comments, maybe we can hand over to the faculties for the closing remarks.
I'm sorry, I didn't hear the last part. Could you please repeat it?
No, Mr. Emil, I was just asking, what is your final call on this case scenario? Of course, you have shared your detailed viewpoints on this particular case, but anything you would like to add here as an end point?
Yeah, here we have other government schemes and all for disabled people. So we will, if it was here, we will try to avail that for them. And the final goal is always to make the patient as much as independent, as much as possible, independent as much as possible, and to the well-being of the child also. If the parent is not able to take care of the child, I think we should look for other options also. That is also in consideration. That's all. That's all. That's all from our side.
Thank you very much for all your inputs.
Thank you. Thank you, Dr. Amrita. Very relevant case for today's discussion. And personally, I am happy that we could learn the different aspects of these things from 3 different countries right now, from Nepal, from UK, and from India. So that was personally a very enriching learning experience for me. And I believe that everyone would agree to that. And so
Priya, 1 minute.
yes, sir. Sorry, sir.
Can
Thank
you
you for joining in.
can you actually I couldn't hear the patient case history. Can you just give me in a nutshell about this patient?
Sure, sir. Sure. Today we were discussing about 18-year-old female, and pardon me, I am a non-medical person, so this was the diagnosis. Dr. Amrita, or would you like to just?
Yeah, no. Just
Okay.
show me. That's all.
Okay. This was the
Yeah.
diagnosis, sir, and
Yeah. Okay. 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 Okay.
these were the meditations we given.
Yeah. Okay. Yeah, it's okay. Sripriya.
And so we were discussing, like Dr. Amrita was sharing her concern, like apart from being a medical professional, this was something personally like very confusing, and we were in a dilemmatic state because presently the situation is that the husband or the father of the kid, that 8-month-old kid, actually the husband and wife both are 18 years old, and the young boy or the young father had given up his hope, his dream of going abroad, and is staying back jobless to support his wife and that 8-month-old child. That is the present situation. And anything more you would like to add here
Okay.
briefly, Dr.
Sripriya.
Amrita?
I had a discussion about this patient, but I think I don't know whether this has been discussed because I had you have been discussing many things about support groups. The father and mother are grown-up child, etc., etc. So you had a very good discussion, and you got opinion from 3 countries. So what I didn't hear is something which we usually don't talk. That is about the sexuality. I don't know whether that was talked about this patient.
No, sir, no.
Yeah. So this is something which we usually don't talk in India to the patient, but sexuality doesn't mean that it is not only the act of intercourse. It actually includes the intimacy. So I think at this age of 18 years, I think that is very important. And if I don't know whether I have seen many patients who are paraplegic, and most of them are married, but still they are at night. Both of them will be in the in separate rooms because the society and the family has a tendency that these people doesn't have sexuality or asexual, but being together in a room is most important for both wife and the husband. So even I had a patient who used to come to our hospital. This was a young man who is paraplegic, and the family won't allow the wife to stay back with this man at night. So this young man come to palliative care OPD just to get admission so that his wife can stay with him in the room. So that's something which we usually don't talk and we neglect it. I don't know about the UK situation. Probably they would be talking about it. But in India, it's a usual thing. Nobody will talk about this. So maybe I think it is important to explore their concerns from the sexual point of view. Somebody has to, it is our inhibition that we will not talk about this. But if you talk to this, to the patient, they actually are eager to talk. And even I did a study on paraplegic, and what I heard them from had was they want to talk, but nobody is talking about it. So that's a fact. I think this is something which all you have to keep in your mind, not only in case of paraplegic, but for any patient, the intimacy is very important. Yeah, thank you, Sripriya. I just want to make that point.
Thank you. It's something that I didn't really think about. Thank you very much.
So true, so true. Like we were just at the verge of winding up without discussing the one of the most important points. Thank you for joining in. I believe all of you know Dr. Sunil is the additional director of TIPS, Trivandrum Institute of Palliative Sciences, and actually, since Dr. Sridevi was not joining us for the day, we had requested him to join, and he's such a very busy person with a tight schedule. Still, he managed to join in at the moment. Thank you so much for that, sir. And sorry, I couldn't like recognize you joining in because my screen was shared. Sorry for that. So,
That's okay. Yeah.
in between, like Dr. Kanmani had also raised a similar question while I think Sir was talking, is if the paraplegia is considered permanent, husband being only 18 years, in the long run, he might want to have another wife. How do we approach this, and how do we counsel the patient and her husband in such a scenario?
Emil or Sara?
So we have different section with the husband and the wife, and we will hear their both their concerns, and we will talk to their parents also. And now currently they are 18, and we will ensure them they're getting support, good support from their family members, and getting good support from their family members or their friends or their any support systems.
Yes, thank you, Sara. I think a lot of discussion is needed separately with the patient and with the husband and also with the family. And we have to understand what does the father or the patient's husband understand about the paraplegia. I think transverse myelitis. I don't know whether it is she's going to become better. During my internship, he was diagnosed with transverse myelitis, and he was bedridden. And then we discharged the patient after giving steroids and things like that. But after I think 2 years, I met this patient again when I worked in palliative care. So by that time, he was able to walk with the help of crutches. So we don't know how transverse myelitis is going to progress, um, but she might need physical rehabilitation, which I think would have some role in the rehabilitation of this patient. So all of these things has to be taken into consideration, and I think somebody should talk openly to the husband and what does he feel about this, um, about what is his concerns, and yeah, it is basically exploring what does the husband think about the patient situation and how he see the future. So from that we can understand what he want to do. So I think that would be the starting point from where we need to take the conversation forward.
Thank you, sir. Thank you. Dr. Yan had also commented that we would address future contraception for the couple, as introducing another child in the situation would be tricky.
Yeah, that's very important. But yeah, we have to talk about this, and husband and wife has to come to a common platform, and they have to decide it. But it's our duty to talk about this issue. That's very important.
Thank you, sir. Anyone else would like to add on points or any queries you still have which needs to be addressed?
Um, just a question from my side, like these as a pediatrician, when I deal with children with disabilities, I mostly talk to the the parents, of course, to get their history mostly, and then I don't know, like in the beginning when I started out, I felt more like a counselor, because there was so much to talk about, and I would just spend like maybe 45 minutes or 1 hour with them. and they would just, I mean, you know, feel so different about like being with a doctor who's like listening to them, you know. And so I kind of I mean, this psychosocial or, you know, psychological issues are very close to my heart because of, you know, how I've dealt with my patients. So I don't know, it's like you know, like, okay, this is a part of the counselors, or, you know, like, of course it's a multidisciplinary team, but then as a physician, you know, I get invested in them too. And so how you know, as a physician, how do you, I don't know, you know, the kind of the right words to say to ask my question actually, but what I'm trying to say is, you know, how should my approach be in all of this, you know? Just
That's a good question. So we are not professional counselors or psychologists, but I think the patients would like to talk to us regarding anything that they are facing. So it may not be necessarily the physical problems. And as you rightly told, in the patient's case, I think it will be most of listening that you need to do. Because she has a lot of things to talk, and maybe every time she is going to talk about the same thing, and you might be bored, and there will not be anybody else who is going to listen to her. But I think it is important to hear her, and we may not have any solutions for the things which she come up with, but I think it is important to listen to her. That's all what we can do in certain situations. But there will be something which we will be able to do. So that's, but it is also important that we should not give any false hope. We should give realistic hope to the patient. And I think reassure her that whenever you want, we are there to listen to you. And we will do whatever possible from our side. So I think even if you are not a counselor or psychologist, it is important for you to listen to the patient. And I think that will take a lot of time, and that will be your main role, I think. And if there are somebody in your team, like a social worker or somebody else, I think please, or nurses who can talk to her, please involve them so that your time maybe it can be saved. But even then, the patient might want to talk to you. But it
Yes.
is important that there should be a few people from your team who is going to make connections with connection with this patient and family.
Yes, thank you. But yeah, the difference I've noticed is like the patients, the parents, they're happier when we just listen to them. Yeah, and yeah.
Could I say that I think in all patient interactions, if you have a degree of emotional investment in that relationship, they immediately recognize that and appreciate it. But that emotional investment on any clinician's part comes with a degree of cost. And you might be hinting at a deeper question, which is about how can you remain empathetic and how can you show compassion without burnout, the risk of it costing you too much. And that would be a great topic, perhaps, compassion without burnout, or self-care for the caregivers, because that addresses both professionals involved and self-care for caregivers. We've been talking about caregivers today. And I love the little section about 4 types of caregivers. All of us at some point will be a caregiver or on the other end receiving care. So self-care for carers is really important. But that's more than an hour and a half of one of these sessions, but might be a good one for the future. Anyway, I'll say no more about that at the moment, perhaps later.
Yeah, thank you. I think that's an important point, self-care, especially because Dr. Amruta, who is also young, and she is going to take care of a young lady.
Sorry, I
who-
only look young. I'm not very young.
But you, you, I don't know, but still, I think when the patient is near to your age, or if you have a sister, elder sister, who is, or younger sister who is having the same age, then probably as it will be very difficult for us to see her as a patient, and we will actually look at her as a sister or somebody else. That will cause more distress within you. So that it is important that you should find out sometime, not sometime, some way for self-care. Otherwise, you will go into burnout. So thank you for introducing that topic.
Can I just for a minute? I'm sorry to.
Yes, please.
Yes. Just to go behind both of your talk discussion points, Dr. Ian's and Sir's discussion point. See, I am basically a surgeon. We have a teamwork going around us, not just our students. We also have dietitians moving around with us. We have we have clinical pharmacists moving around with us. So we have a big team around us. Of course, as Dr. Amrita said very clearly, the patients always look up to the doctor. And it's very easy for the patient to get attention only to what the doctor says. So the trick that we do here is that when we want to discuss a specific problem related to other subspecialties, we need to get a help of them. I bring all of them together. Those people who are involved also are brought together, and sitting with me and the patient or relatives, I tell them, look, I listen to them. I tell them, yes, very good, excellent. And then I point to these people who are around me, who are the real people who are going to help the patient out, and tell them that they are the best available. And I will support them also. And so that we form a big team. You, that means the patient, me, and the other people, say this person A, person B of this department. He's a qualified dietitian. He's a qualified clinical pharmacist. He knows about the drugs that we are writing. So in other words, we are promoting confidence into the people who are coming to help me, as well as the patient is slowly going to develop confidence in those people. And once we sit together and do this 2-3 times, then probably the patient will say, I will talk to that person, the pharmacist or whoever it is. So that's one of the tricks that we do here. Thank you.
Yeah, that's also an important point. If Dr. Amrita has a team, nurse, social worker, somebody else, as I told you earlier, that would be good, because everybody in your team will be in the same page regarding the management or any issues. Otherwise, it will make more confusions. And you are also promoting your staffs to take more responsibilities, and you are making them capable of dealing with the situation. And we actually have a multidisciplinary team meeting to discuss every patient every morning, so that doctor, nurse, social worker, physiotherapist, everybody will be there to help the patient, so that everybody knows what is happening, so that they will be able to help the patient in a better way. Thank you.
Thank you very much.
Thank you, Dr. Sunil. And I believe that what was going to end as a mere um, over the brim discussion now turned out to be a very deep and very enriching and enlightening one, I suppose. Thank you. A special thanks to Dr. Sajid and Dr. Ian for putting in your wise words, because your years of experience does speak for yourself. So much of experience, and I believe everyone out here is fortunate to have people like you joining us for the foundation course, so that we come to learn more things. Basically, it is a process of learning, unlearning, and relearning. Thank you so much. Sunil sir, any closing remarks from you before I hand over to the faculty and then sign off?
No, I think that was a very good discussion, Sripriya.
Thank you, sir. Thank you, Miss Sara and Mr. Emil. And of course, they are the people who literally roam around the Trivandrum city every day, taking care of the beneficiaries. And thank you so much for taking your day off your schedule and joining us for this wonderful discussion. I believe that you also got something new to learn from the valuable discussions. So with that positive note, this is Shripriya along with Ms. Sara Varghese and Mr. Emil George and Dr. Sunil Kumar signing off from the Tips Eco Hub. See you in the next session with another interesting topic. Till then, everyone, take care. Bye-bye. And please don't forget to leave your feedbacks. Bye-bye.